We know that substances though whose solutions conduct an electric current are called electrolytes. There are about 11 electrolytes like sodium, potassium, calcium and magnesium cations, whereas chlorine, HCO3, HPO4, SO4, organic acids and proteins are anions. Among these, sodium, potassium and chloride are important in the distribution and the retention of the body water. Students, today we will be discussing about one of the important electrolyte, that is sodium. Let us get to know sodium with an introduction. Sodium is an essential element for all animals and some plants. Sodium ions are the major cation in the extracellular fluid and as much as major contributor to the extracellular fluid osmotic pressure and extracellular fluid compartment volume. Sodium is a chemical element with symbol Na. It is a soft silvery white highly reactive metal. Sodium is an alkaline metal because it has a single electron in its outer shell that it readily donates, creating a positive charge atom, the sodium cation. The free metal does not occur in nature but must be prepared from compounds. Sodium is the sixth most abundant element in the Earth's crust and exists in numerous minerals such as feldspars, solidite and rock salt. Many salts of sodium are highly water soluble. After reading this episode, you will be able to understand the distribution of sodium in the body, elaborate on the absorption, discuss the utilization of sodium in the body, identify the food sources of sodium and explain the deficiency as well as toxicity. History of sodium. Although sodium, sometimes called soda, had long been recognized in compounds, sodium was first isolated by Humphrey Davy in 1807 by the electrolysis of sodium hydroxide. Because of its importance in human metabolism, salt has long been an important commodity as shown by the English word salary, which derives from salarium, the wafers of salt sometimes given to Roman soldiers along with their other wages. In medieval Europe, a compound of sodium with the Latin name of sodanum was used as a headache remedy. The name sodium is thought to originate from the Arabic suda, meaning headache, as the headache alleviating properties of sodium bicarbonate or soda were well known in early times. In 1809, the German physicist and chemist Ludwig Wilhelm Gilbert proposed the names natrium for Humphrey Davy's sodium and kalium for Davy's potassium. The chemical abbreviation for sodium was first published in 1814 by John Jacob Berzelius in his system of atomic symbols and is an abbreviation of the element's new Latin name natrium, which refers to the Egyptian natron, a natural mineral salt mainly consisting of hydrated sodium carbonate. This episode gives an overview of sodium, how sodium is distributed and absorbed in the body, what are its vital role in human body, what are the ill effects are the few issues discussed in this episode. Coming to distribution. The adult human body contains about 100 grams of sodium ion. About 1/3 of the total sodium content of the body is present in the inorganic portion of the skeleton. 50% of the sodium is present in the extracellular fluids, 40% in the bone and 10% in the intracellular fluid. Plasma contains 330 mg per 100 ml, muscles 60 to 160 mg per 100 gram, cells 85 mg and nerve contains 312 mg per 100 gram. Let us start absorption. Normally, sodium is rapidly and completely absorbed from the gastrointestinal tract. It is absorbed in the jejunum region of the small intestine by active transport. Simultaneously, presence of glucose and amino acids enhances its absorption. It is also actively absorbed in the ileum and in the colon except the rectum. Three basic pathways operating the sodium absorption across the intestinal mucosa brush border membrane are: 1. The sodium glucose co-transport system, which functions throughout the small intestine. Secondly, an electrol sodium and chlorine co-transport system. This is active both in the small intestine as well as in the proximal portion of the colon. And thirdly, pathway in an electrogenic sodium absorption mechanism, which operates only in the colon. The sodium glucose co-transport system involves a carrier on the brush border membrane of the small intestine, both being a carrier which carries them from the outer surface to the inner surface of the cell membrane and are released before the carrier returns to the surface. Further, the absorbed sodium is pumped out across the basolateral or serosal membrane by the sodium-potassium ATPase pump. This provides the energy needed to maintain the absorptive direction of the ion. The electroneutral sodium and chlorine co-transport system mechanism is a way where significant proportion of sodium uptake requires the presence of chlorine and vice versa. The mechanism allows both sodium and chlorine to enter the cell where they are exchanged for hydrogen ion and HCO3. Absorbed sodium is pumped across the basolateral membrane by sodium-potassium ATPase pump, where chlorine crosses by diffusion. The colonic mechanism is called as an electrogenic sodium absorption mechanism because the absorbed sodium ion is the only ion moving transcellularly, allowing its transport to be monitored. It enters a luminal membrane of the colonic musical cell through sodium conducting pathways called sodium channels, diffusing invariably by the downhill concentration gradient of the ion. The absorbed sodium along with water and anion moves as net water and electrolyte from the luminal side to the bloodstream side of the colon epithelium. It is pumped out across the basolateral membrane on the bloodstream side of the cell by the sodium-potassium ATPase pump. The absorbed sodium is transported freely in the blood. The hormones like antidiuretic hormone or vasopressin, aldosterone, atrial natriuretic hormone, renin and angiotensin II maintain the sodium balance in the body. Excretion. The excess gets excreted through urine, feces and sweat. Sodium excreted in sweat and feces is minimal, bulk of it being excreted in urine. Kidney regulates the sodium balance in the body. For example, when the intake of sodium is high, the excretion is likewise high. When the intake is low, the excretion decreases. The loss of sodium also depends upon the concentration and total volume of sweat. Normally, in warm weather, the initial losses will be high, and with accumulation, there will be reduction in the sodium in perspiration. Renal retention and excretion of sodium is controlled by the hormone. Factors affecting the absorption and excretion of sodium. Blood pressure drives both urine volume and the amount of sodium filtered into the proximal tubule, while increases and decreases in natriuresis pressure can help regulate sodium homeostasis when such pressure changes occur as a result of disease like hypertension or other causes. The increase or decrease in pressure can cause imbalance in sodium. Changes in blood volume quickly lead to changes in cardiac output and blood pressure. Blood pressure changes can lead to changes in sodium excretion. Renal retention and excretion of sodium is controlled by the hormones. Antidiuretic causes the epithelial cells of the distal convoluted tubules to become more permeable to water, thus concentrating urine and saving water during times of water stress. Decreased levels of angiotensin II result in decreased reabsorption of sodium in the renal tubules. Thus, decreases in angiotensin II are seen following increase in sodium intake. Angiotensin II works by modifying the nucleus pressure mechanism, decreasing. Sympathetic activity can constrict renal arterioles, increase tubular reabsorption, and stimulate renin release, all leading to increased retention of sodium. This type of a reflex is likely to occur from decreased blood volume as following a large hemorrhage. Sodium absorption in the ascending limb of the loop of Henle, the distal convoluted tubules and collect ducts is greatly influenced by the amount of aldosterone excreted by the adrenal cortex. When sodium level drop, the adrenal cortex secretes aldosterone, which results in an increase in the active reabsorption of the sodium. Now we shall discuss about its vital role played in the human body or how body utilizes this. In humans, sodium is an essential mineral that regulates water balance and water distribution along with blood volume, blood pressure and pH. Sodium is utilized by the body as a major component of extracellular fluids. It is also associated with the anions chloride, bicarbonate, phosphates and lactate. Sodium maintains osmotic equilibrium of the body fluids and thus protects the body against excessive fluid loss. Along with chloride and bicarbonate, it plays a vital role in acid-base balance. Sodium helps in the absorption of glucose and galactose from the small intestine. The normal neuromuscular functioning is maintained by sodium. The permeability of cells functions normally is in the presence of sodium. The sodium pump maintains electrolyte difference between intracellular and extracellular fluid compartment. We will try to identify the dietary sources of sodium now. Sodium occurs naturally in most foods. The most generic form of sodium is sodium chloride, which is table salt. Milk, beets and celery also naturally contain sodium. Drinking water also contains sodium. Sodium is also added to many food products. Some of these added forms are monosodium glutamate, sodium nitrate, sodium saccharin, baking soda and sodium benzoate. Salt is extensively used in food processing and manufacturing. Processed foods like pickle, chips, condiments, cured meats like bacon, sausage, ham, cheese, canned soups, canned foods, canned fish and vegetables contain added sodium. Fast foods are generally very high in sodium. Deficiency. Deficiency of sodium do not occur normally because of the abundance of the mineral across a broad spectrum of foods. Deficiency of sodium is called as hyponatremia. Serum concentration of sodium normally range within 135 to 145 milliequivalents per liter. Hyponatremia represents a decrease in the serum sodium concentration below the lower end of the normal range. Symptoms of hyponatremia include muscle cramps, nausea, vomiting, dizziness, shock and coma. There may be lack of fat deposit, lung infection can occur, deficiency of osteoid tissues leading to slow growth, low weight due to loss of water. Hyponatremia causes dehydration, reduced blood pressure, decreased blood volume and circulatory failure. The risk factors for hyponatremia include use of diuretics, liver failure, heart failure, myocardial infarction and endocrine changes which are mostly found in older patients. Hyponatremia is associated with various conditions that can be grouped into dilutional disorders characterized by water intake in excess of output. The condition implies impaired water excretion and depletional disorders caused by sodium depletion in excess of water, depletion or replacement of fluid losses with water alone. Insufficiency of adrenal corticosteroids decrease sodium level with increased sodium excretion. Chronic renal disease depletes sodium due to poor tubular reabsorption as well as to the loss of sodium in the buffering acids. Toxicity. Loss of water from extracellular fluid compartment increases the sodium concentration, a condition called hypernatremia. Isotonic loss of water and sodium from the extracellular fluid compartment decreases the size of that compartment in a condition called extracellular fluid hypovolemia. Hypernatremia represents an elevation in the serum sodium concentration above the higher end of the normal range. Clinical signs and symptoms associated with hypernatremia include hypertension, increased extracellular fluid volume, and increased extracellular fluid osmolarity, resulting in intracellular fluid loss. It is associated with abnormal renal excretion of water with inadequate water intake disorders such as in pituitary ADH deficiency and nephrotic syndrome, in which kidneys are ADH unresponsive, or with osmotic diuresis such as severe glucosuria and mannitol diuresis. Other diseases and states that may be accompanied by hypernatremia are chronic renal failure, recovery phase of acute renal failure, hypocalcemia, hypokalemia, and sickle cell anemia. In today's episode, we have learnt about sodium starting from the distribution, absorption, excretion, deficiency, and toxicity. Now let us sum up the episode. Sodium has occupied a unique position in human history. Sodium is a principal cation in extracellular fluids. It regulates plasma volume and acid-base balance, involved in the maintenance of osmotic pressure of the body fluids, preserves normal irritability of muscles and cell permeability, activates nerve and muscle function, maintenance of membrane potentials, transmission of nerve impulses, and the absorptive process of monosaccharides, amino acids, pyrimidines, and bile salts. Sodium is readily absorbed as the sodium ion and circulates throughout the body. Excretion occurs mainly through the kidney as sodium chloride or phosphate. There are appreciable losses in perspiration. Increased level of sodium in the serum is called low level of sodium in the serum is hyponatremia, and this occurs in acute Addison's disease, vomiting, diarrhea, nephrosis, severe burns, and intestinal obstruction. Sources include table salt, salt added to prepared foods, and most natural foods contain sodium. Thank you, students. Hope you have understood sodium.